Picture this. You're 74, feeling genuinely well, sleeping fine, energy is decent. You go in for a routine physical. Your doctor says, let's just run a few tests to be safe. 6 weeks later, you're in a surgeon's office. Not because anything was wrong, but because one of those just-to-be-safe tests found something. That chain of events plays out more often than the medical system likes to admit, and it deserves a serious, honest conversation. Not a scary one, an informed one. Here's something worth knowing that rarely comes up in a rushed 15-minute appointment. After age 70, some routine medical tests can genuinely do more harm than good. Not because medicine is broken, but because the risk-to-benefit math shifts meaningfully with age. And often nobody is doing that math out loud in the room with you. Today we're going through 5 specific screening tests worth reconsidering after 70. What the actual research says, why the calculation changes, and a set of 5 questions that can change the entire conversation at your next appointment. Stay through all 5. The 4th one surprises a lot of people. And the 5th is one most people have never even heard of. Before we get into it, where are you watching from today? Drop your country or region in the comments. I read everyone. To be clear from the outset, this is not an argument against seeing your doctor or against screening in general. It is about understanding which specific tests genuinely earn their place after 70, and which ones deserve a more careful conversation first. Before the 5 tests themselves, there's one concept worth understanding first, because without it, the rest won't fully land. At 50, screening medicine works beautifully. You catch something early, treat it, and potentially gain decades of healthy life. The math is clean. 3 things generally change after 70. First, many conditions found through routine screening in older adults grow slowly enough and cause few enough symptoms that a person is statistically likely to live their full life alongside them rather than because of treating them. Second, tolerance for invasive intervention generally declines with age. A procedure a 55-year-old recovers from in 2 weeks can mean a much longer, harder recovery, sometimes with lasting complications, for someone in their late 70s. Third, there's something researchers sometimes call a cascade effect. One test flags a small abnormality, which leads to a follow-up scan, which leads to a biopsy or procedure, which carries its own risk of complications. A chain that can start from a test that wasn't strictly necessary in the first place. None of this means screening is bad, or that catching disease early stops mattering with age. It means the calculation genuinely shifts, and it's worth understanding that shift before your next appointment, not during it. It is worth naming that none of this is about doctors doing anything wrong. A busy 15-minute appointment simply does not leave much room for this kind of nuanced risk-benefit conversation, which is part of why it is worth bringing some of that thinking in yourself. Checkup 1. Routine colonoscopy screening after age 75 for people with no symptoms and a clean screening history. The U.S. Preventive Services Task Force, the body that sets national screening guidelines, recommends against routine colonoscopy screening for average-risk adults over 75, with no symptoms, no relevant family history, and clean prior results. This is official published guidance, not a fringe opinion. The reasoning comes down to the same risk-benefit shift. Bowel perforation from colonoscopy is uncommon overall, but the real procedural risk, combined with how often colon cancers found in asymptomatic older adults tend to grow slowly enough to never cause a problem in someone's remaining lifetime, is part of why the task force draws the line where it does. The bowel prep process itself is also worth naming honestly. The preparatory liquid taken the night before can be genuinely hard on the kidneys and electrolytes in an older body, and dehydration from prep is a documented, real complication in its own right, separate from the procedure. None of this applies if you have symptoms, blood and stool, unexplained changes in bowel habits, unexplained weight loss, or a strong family history. Those situations change the equation entirely and are worth prompt evaluation. What's worth asking about instead if you're average risk and asymptomatic, non-invasive stool-based tests like an annual FIT test or a stool DNA test, which can flag genuine warning signs without the procedural risk of a full colonoscopy. It is also worth knowing that these guidelines are specifically about average-risk, asymptomatic adults with a clean prior screening history. Someone with a personal or strong family history of colon cancer or any prior polyps is often in a meaningfully different risk category where continued screening may make good sense. A yearly stool-based test done consistently tends to catch the same meaningful warning signs a full colonoscopy would for most average-risk people in this age group without the bowel prep burden or the procedural risk, which is exactly why it is worth asking about specifically. If you're finding this useful, type the number 1 in the comments. It helps me know you're following along. Checkup 2. Aggressive PSA prostate testing and routine annual mammography in average-risk asymptomatic patients over 75. I want to be precise here because this deserves real nuance. Cancer screening has saved a great many lives, and this is not an argument against screening in general. The specific concern researchers raise is about overdiagnosis in this particular population. Imaging and blood tests today are sensitive enough to detect very slow-growing, biologically indolent cancers that would likely never cause a symptom or shorten a person's life if left entirely alone. The complication is that once a report uses the word cancer, the clinical process tends to move forward by default. Biopsies, specialist referrals, and treatment decisions, largely regardless of whether that specific cancer actually posed a meaningful threat. Research published in journals, including the New England Journal of Medicine, has found that a meaningful share of cancers detected through mammography in women over 70 were unlikely to have caused harm if left untreated, meaning the treatment itself carried side effects without a clear survival benefit for that specific case. This is genuinely individual. If you have a family history, known genetic risk factors, or any symptoms, screening conversations look different and are worth having proactively. If you're average risk and asymptomatic, one specific question tends to open up a much more useful conversation. If this test finds something, what would the realistic treatment options be for someone my age? And what would you actually recommend? It is worth adding that this overdiagnosis concern is specifically about average risk screening in people without symptoms. Anyone experiencing urinary symptoms, unusual lumps, or other concerning changes should absolutely be evaluated promptly. That is a completely different clinical situation from routine screening in someone who feels well. Checkup 3. Routine cardiac stress testing in people with no cardiac symptoms at all. This one surprises people, because on the surface it sounds like simple, responsible caution. Here's the complication. In people without symptoms, cardiac stress tests carry a meaningfully high false positive rate in some populations, meaning the test can flag a concern when the heart is in fact fine. And a flagged result doesn't typically end there. A false alarm often leads to cardiac catheterization, threading a thin catheter through a blood vessel into the heart to look more closely. It's a genuinely useful procedure when appropriate, but it carries real risks of its own, including bleeding, vessel damage, and rare but serious complications. Here's where it gets genuinely counterintuitive. Partial blockages are extremely common in adults over 70, including in people with no symptoms at all. And a landmark trial called Ischemia, a large, well-known randomized study, found that adding stenting to medication for people with stable coronary artery disease did not reduce heart attacks or extend life compared to optimized medication and lifestyle management alone. That's a significant, well-established finding worth sitting with. The stent in that specific population didn't outperform medication, while carrying its own procedural risk. Plus, the ongoing need for blood thinners and their own bleeding risk. If you have no chest pain, no unexplained shortness of breath, and no dizziness during activity, this is worth a direct conversation with your doctor about whether routine stress testing makes sense for you specifically, versus focusing on the modifiable factors: blood pressure, cholesterol, blood sugar, activity, and sleep, where the evidence for benefit is considerably stronger. It is also worth knowing that this conversation looks different if you do have symptoms. Chest pain, unexplained shortness of breath on exertion, or fainting spells are not things to watch and wait on. Those warrant prompt evaluation, stress test, or otherwise. It is worth adding some context on scale here. The ischemia trial specifically enrolled people with stable, non-emergency coronary disease. Anyone experiencing an acute cardiac event is in an entirely different clinical situation, where intervention is often exactly the right life-saving call. Checkup 4. Routine bone density scanning that leads automatically into long-term bisphosphonate medication. I want to be careful here, because osteoporosis and falls are genuinely serious concerns in older adults. Nothing here questions that reality. What's worth questioning is the automatic pipeline that sometimes follows a low bone density result specifically. Long-term bisphosphonate use, medications like alendronate or risdronate, has been associated with two rare but serious complications: atypical femoral fractures, spontaneous stress fractures in the thigh bone the medication was meant to protect, and osteonecrosis of the jaw, a painful, difficult-to-treat condition. Meanwhile, one of the most effective interventions for preventing fractures in older adults isn't a medication at all. It's fall prevention. Balance training, including Tai Chi specifically, has been studied for its association with meaningfully reduced fall risk, alongside removing home tripping hazards, installing grab bars, checking for medications that cause dizziness, and getting vision checked regularly. None of this means medication is never appropriate. For people who've already had a fracture, or with very low bone density scores, or specific risk factors, it often is exactly the right call. The question worth asking is narrower. For someone who's never broken a bone and is otherwise healthy, is medication the first step? Or is a structured fall prevention approach worth trying first, alongside monitoring? It is worth mentioning that vitamin D and adequate protein intake are also part of the well-supported, low-risk side of this equation. Foundational habits that support bone health directly, alongside balance training, without carrying the specific risks associated with long-term medication. It is also worth knowing that a DEXA scan itself is a low-risk, valuable piece of information to have. The concern here is specifically about what automatically follows a low score, not about getting the scan in the first place. If you're getting value from this, type the number 4 in the comments. It's a simple way to let me know you're here. Checkup 5. And this is the one almost nobody talks about. Routine carotid artery ultrasound screening in people with no symptoms at all. A carotid ultrasound checks the large blood vessels in the neck that supply the brain. The logic sounds straightforward. Find a significant blockage, clear it surgically, reduce stroke risk. The reality for asymptomatic patients specifically is more complicated. The surgical procedure used to treat a carotid blockage, called a carotid endarterectomy, carries a real perioperative stroke risk of its own, commonly cited in the low single digits as a percentage, which sounds small until you consider it's a risk taken to prevent a risk that, in an asymptomatic person, may never have caused a problem at all. The U.S. Preventive Services Task Force explicitly recommends against routine carotid artery screening in adults with no symptoms, no mini-strokes, no vision loss episodes, no other neurological symptoms, concluding that for this specific population, the risk of the intervention outweighs the benefit of finding a silent, stable narrowing that had likely been there, unproblematically, for years. If you have no symptoms of stroke or TIA, no sudden vision changes, no facial drooping, no arm weakness, this is worth discussing directly with your doctor rather than assuming routine screening is automatically the right call. The stronger, better supported investment for most people is managing the modifiable risk factors directly. Blood pressure specifically, blood sugar, smoking cessation, and atrial fibrillation management if relevant. And to be completely clear, if you do have any neurological symptoms, even brief ones that resolved on their own, that changes everything, please get evaluated promptly rather than waiting. It is worth being clear about what does count as a neurological symptom worth acting on immediately. Sudden vision loss or double vision, sudden weakness or numbness on one side of the body, sudden difficulty speaking or understanding speech, even if it resolves within minutes. That combination, known as a TIA, is a genuine emergency, regardless of whether it has fully passed by the time you notice it. Here's something practical to actually use. Anytime a doctor recommends a screening test, especially past 70 while you're feeling well, these 5 questions are worth having ready. Question 1. What is the false positive rate of this test in someone my age? This tells you how likely the test is to trigger a follow-up procedure, even when nothing is actually wrong. Question 2. If this test finds something, what are the realistic treatment options for someone my age and health status? This shifts the conversation from findings to outcomes. Question 3. What is the procedural risk of any treatment we likely pursue? Every intervention carries some risk, and it's worth knowing it up front rather than after the fact. Question 4. What happens if we simply monitor this instead of treating it right away? For a great many conditions found in older adults, watchful waiting with regular monitoring is a legitimate, evidence-supported option, not a lesser one. Question 5. What's the most effective non-invasive option for this specific concern? Often, as with bone health, heart health, and stroke prevention, lifestyle-based approaches perform comparably with meaningfully less risk. A good physician will generally welcome these questions, not be put off by them. If a doctor dismisses this kind of question outright, that itself is useful information about fit. These 5 questions are not meant to create friction with your doctor. Quite the opposite. Framed with genuine curiosity rather than confrontation, they tend to open up a more collaborative, more thorough conversation than a rushed appointment usually allows for on its own. It can help to write these 5 questions down before the appointment rather than trying to remember them in the moment. Appointments move quickly, and having them ready in your phone or on a card removes any pressure to recall them on the spot. There's a real difference between medicine that generates findings and medicine that protects quality of life. After 70, the goal of a screening conversation is well served by staying focused on the second one: your independence, your energy, your ability to keep doing what matters to you. None of this means skipping care or ignoring your doctor's guidance. It means bringing a genuinely informed, collaborative voice to that conversation, which most physicians, in my experience researching this, welcome rather than resist. It is worth remembering that every person's risk profile, health history, and values are different. The point of all of this is not a blanket rule to follow, but a sharper set of questions to bring into a conversation that is ultimately yours to have with your own doctor. One honest note before we close. I'm David Morgan, an AI-generated health educator, not a licensed physician. Everything in this video reflects published screening guidelines and research, including U.S. Preventive Services Task Force recommendations. But it is general educational information, not personal medical advice. Your own doctor knows your specific health history, risk factors, and symptoms in a way no video can, and any decision about screening tests should be made together with them. If this changed how you think about an upcoming appointment, let me know in the comments. And if a routine test ever led somewhere you didn't expect, your experience might be exactly what someone else needs to hear before their own next appointment. Next time, we'll look at something connected to this: the supplements most commonly recommended after 70, and which ones the evidence actually supports. I'll see you there.